you?
For you, bro.
My bunny don't need
We're
any.
trying to pacemaker or something.
My bunny don't need any charge. She's already charged.
Well, I bet they were probably changing the batteries in here.
Okay.
So, good mind, we do have a pledge, and we got no flag, man.
What batteries?
You got caught. Oh, I get it.
I know what's that. I'm gonna take that.
Somebody's crickets?
That's on that.
I mean, whenever the board president wants to start the meeting, I mean,
We're good.
I'm sorry. We're jumping ahead, huh?
Good evening, and thank you all for attending today's board meeting. Today is February 13th, the time is 5:34. Would you all please rise for the pledge of allegiance? Mr. Kanda?
Pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
We'll proceed to the board workshop, 3A, Socorro SISD Health Plan. Mr. Carmona.
Thank you, sir.
Oh, carajo, here, have another one. I got greedy.
Good evening, Board President Guerra, Dr. Espinosa, board members. Can you hear me? I can't hear myself. You can hear me? Okay. I just making sure because I don't want you to miss all this exciting information. That's why. Okay. So tonight, the first two items that I'm going to be covering are mainly updates, and then after the second update, I'll be covering some recommendations in terms of what we're looking at when it comes to our health fund. The first item is related to an audit that was conducted last plan year. I'm sorry, the plan year 15-16, and the audit was suggested by the board and administration to be able to give another second pair of eyes to look at our funding and how, we're actually spending our money when it comes to medical claims, pharmacy claims. And in addition to that, in fact, our third-party administrator is basically doing what we expect them to do. The audit was conducted by a company by the name of Sagebrush, and Ms. Sally Reeves is here in case we need additional information or additional data that I don't have on the slide, but most likely, hopefully, we'll be able to answer your questions. The audit, so what would we do an audit? What's the purpose of the audit? And the audit is, again, to measure the financial performance of how is it that Cigna, in this case, our third-party administrator for our health fund, is processing our medical claims, our pharmacy claims, and or are we receiving the rebates that we were to a point entitled to receive based on the consumption of those prescriptions. In addition to that, we are able to see if in fact, when it comes to high dollar claims, are we paying based on the number of claims? Are those claims being bundled? Are we paying on the rate that we're supposed to be paying, the frequency that we're supposed to be paying, and so on and so forth? Some of those claims could be bound to age, gender, and so on and so forth. When it comes to pharmacy, pharmacy is one of those benefits that you can pretty much see at point of service, meaning the billing or the claim is processed at point of service. So if you show up to a pharmacy, the pharmacy will run the claim right there and then. They'll be able to tell you if you have coverage. If you have coverage, what will be your co-payment? And that will be in contrast with a medical claim, which will require additional information such as diagnosis codes, probably an admission date, discharge date, line of treatment, frequency of the treatment, and so on. So the audit itself, after they pulled a number of data, Sagebrush audit report came back basically just confirming what we had suspected through our relationship with Cigna. They have established systems and controls. They have processed claims accurately. And in addition to that, they compare the trend or the accuracy of how claims are being processed. And typically, if I'm not mistaken, the standard in the industry is 95%. But through the findings, we were able to verify, again, through the audit report, that the accuracy of claims processing is 99.57 and 97.34, respectively. There were no errors identified in the pharmacy, and exceptions were identified with focused tests. And there were a handful of errors that were addressed, though those were no more than 10. And once those were identified, they were basically human error. It was not necessarily a system setup per se and or contractual concerns. Another interesting point is related to the pharmacy rebates. And in this slide, we pretty much are reporting that there was nothing significant that we needed to look at, though I think that it's important to point out that the total rebates that we received in 2016 was 13.9% of our pharmacy expenses, or 1.4 million of what we spend on pharmacy, which is quite a significant amount of money that we're spending from our health fund comes from the consumption of prescriptions. In comparison to the national average, which is 10%, and Sagebrush's clients range from 11 to 20%. So in this case, based on the experience or the results of the audit, we can see that when looking at how Cigna is processing our claims, their accuracy percentage is 13.9, which is well within that standard that Sagebrush has established, again, for their clients. Now, as I mentioned before or earlier, the goal or the purpose of the audit is for us to be able to just confirm what we had suspected from, prior experience in terms of our financials and so on. So the audit concludes that, in fact, we are receiving the rebates. We are getting an accuracy or a certain percentage of accuracy when it comes to claims processing, pharmacy rebates, and so on. I don't know if within this item you have any questions or anything that you'd like for me to further clarify.
Any questions?
I do. Mr. Carmona, so what was the size of the sample, the statistical sample?
So if we look at the medical, 250 claims were pulled, and what we do or what Sagebrush will do is pull a number of claims that have a significant impact on the fund. Not necessarily per se 250 claims that are office visits, because at the end of the day, that financial impact will not be significant. They will look at a high dollar claim, perhaps a surgery, an admission that the length of stay was for days, possibly even weeks. Then once they look at that sample data or that particular type of claim, they'll see that in fact it pertains to the time period, the person, the individual, the level of coverage, that once a claim is processed, they are reimbursing at the rate that they're supposed to be getting reimbursed and so on.
Okay. And then it says provide benchmarks for comparison to guarantees. What guarantees?
You're looking at which slide, I'm sorry?
Number 4.
So through our contract with Cigna, there is a list of performance guarantees. And what they would do is see what the guarantee is per se, just to, I guess, give you general information. For a specific type of drug, your rebate should be so much for this number of consumption. Then they would go back into the contract and see that in fact, Socorro ISD received that number of, or that amount of refund or rebate for that particular number of items that were consumed.
So I don't see anywhere in here where it states us whether all the guarantees included in our contract were met or not.
The intent of the audit was not to evaluate performance guarantees, it was to evaluate how claims were being processed. But we can look into that if you like.
Okay, because certainly, I don't know if you're aware, Mr. Carmona, but this is right up my alley. The customers of the company that I work for help guide hospitals to keep their claims rejection rates at about 3%. It doesn't surprise me that Cigna can process these claims accurately because that's the very purpose they serve. The challenge is typically on the hospitals to make sure that they're billing correctly so that, they can process those claims because as I look through most of these things, most of these are denials that insurance companies issue automatically, probably within 30 days of receiving a claim, whereas it'll take hospitals, anywhere from 60 to 120 days, depending on what the criteria established is, to reprocess and reissue that claim because, of course, it has to be corrected. Does Cigna require that we bill our pharmacy services with drug codes?
The Cigna, it's a system, it's system fed, so let's say when you go in or I go into the pharmacy and they run that particular prescription number, that if in fact I'm an individual who has that type of coverage, it runs with that number.
Yeah, and that I understand. Again, that's right up our alley, national drug codes. It's what we help hospitals do as well. When you're talking about prescriptions from Walgreens or Walmart or anybody else, if they don't bill with the right code, they don't get paid. So I was wondering, but then again, if Cigna doesn't require it, you don't have to include it. And there are very few states that do require it. So I was just, it would catch me by surprise that.
And if I may, Ms. Sally Reeves mentioned that it is required.
Okay. Okay. That's it.
Mr. Gonzalez.
Thank you, sir.
Yeah, I got a question. I did not understand exactly. The claims that, as far as pharmaceuticals are concerned, that Mr. Nájera was talking about, are those drugs or prescriptions they're going to be given or administered at the hospital.
It could be a combination of.
Excuse me?
It could be a combination of. There's also specialty drugs, which are the type of drugs that are high in cost. So if we need to look at the type of medication that's being administered for a certain diagnosis, then we'll look at that. Because there's some medications that are gender bound that may not be administered for someone at a certain age, and so on and so forth. So it all depends on what type of prescription we're looking for and what type of line of treatment the individual is following.
I guess my question was, what percentages of drugs are administered and followed by the hospital versus the amount of prescriptions that you take a prescription and go to Walgreens or Walmart and whatever and get your prescriptions? And the price difference. I mean,
So if I understood correctly, the question is more so in terms of cost of a prescription while you're being an admitted patient versus an
Well,
outpatient?
the thrust of a question that Mr. Nájera had, he questioned the price of the drugs at the hospital. They're going to be administered at the hospital. Now, once you get out of a hospital, you get a script and you go to Walmart or any other drug company and get your medications. Are those medications going to be lower or higher? And if so, by how much?
Into the mic, or put it in.
Oh, sorry.
Mr. Carmona, if I may, I'm sorry, Mr. Gonzalez, so the cost basis is gonna be different if you're purchasing drugs in the hospital versus getting it from a pharmacy. The only way that you can get drugs in a hospital is if they're IV or you don't have the ability to take the drug yourself. So most of the time, as you look at drugs, you can't compare the two, what you get in a pharmacy versus what you get in a hospital, because the method of delivery is different. In the instance that they do, it is because hospitals have retail-based pharmacies, and in order to drum the business, they have to be competitive. So the comparison, I'm not sure is possible, simply because of the types of drugs, and then, of course, the cost basis is
Well-
completely different.
If we pay $100 for medication of one kind or another, I don't care if in the hospital or down at Walgreens, what percentage of our expenditure is consumed by the hospitals and what percentage is spent by the rest of the drugs?
Okay.
I mean, ultimately, we're going to be paying for the whole thing, right?
Absolutely, and like Mr. Nájera said, the expense itself will be different. Just to add to what he elaborated on, the prescription at a hospital will require an administration fee as well. So I don't have an answer for you in terms of amounts or percentage, but we can get that for you.
Yeah, I'm just interested in finding out of the total amount of money we spend in medication, what portion of that money is used in the hospital and what portion of that money is used somewhere else.
I don't think you're going to be able to determine that either. What you can do is calculate total percentage of expenses associated with pharmacy benefits versus hospital, but the way hospitals bill is with a single bundled rate. So when you go into the hospital, depending on your diagnosis, your charge could be $1 million, but Cigna could say, okay, you treated this patient for pneumonia, and I don't care what you charged them, according to our contract, you're going to get paid $5,000. And it's $5,000 for the entire stay, not Cigna doesn't designate you're getting $1,000 for room and board, $1,000 for pharmacy, $1,000 for x-ray. It's simply $5,000, that's your payment, and write off the rest, because that's what our contract says.
If I could add what Mr. Nájera said, your request is real complex on the hospital side, because medications in the hospital side not only come IV, but you might be administered a one-time dose of a medication opposed to a prescription for 30. Some medications come in the form of ointments and creams and gauzes and those types of things that may fall into a medication category. So not that it's not possible to pull out what was the cost for medication, but when you go to the pharmacy, you pay a certain amount of money for medication, and they've built in the pharmacist's cost and their overhead and so forth, which we hope maybe someday we can beat on that. But the hospital also tracks, the stocking fee. How much are they going to pay the nurse to administer that? I'm not sure if it's apples to apples, sir. I think what your question.
I understand that. The only thing I have a question with is, of the $100 that we have available, how many dollars go to the administration or buying the drugs at the hospital, and how many dollars we spend in the other ones? That's the only question I have.
Okay, and like it was said or mentioned already, we may not be able to pinpoint down to that level, but we can absolutely bring over a report based on utilization, and that could possibly give us an idea of how we're spending the money in terms of inpatient, outpatient, and so on.
At the end of the day, this was all outpatient.
Correct.
So
Pharmacy.
this number's outpatient. The inpatient numbers are different numbers. We kind of went over this in HR the other night.
Thank you.
Any other questions on the audit?
Oh, I do have another question. I'm sorry. I know, right?
He was ready to move forward.
Mr. Carmona,
Yes, sir.
I thought they were also going to evaluate what we reimburse per claim compared to other organizations within our market, to see if there were specific fees that we may be able to renegotiate based on our competitive market?
We don't do individual negotiations.
Oh, okay. All right, never mind, I'm confusing the two, or confusing different things.
Continue, Mr. Carmona.
Any other questions on the audit? No? Okay. The next item is just a FYI in terms of the employee clinic. This is an item that we have discussed in prior meetings. Just an update, we're bringing back this item, and most likely this will be something that our insurance consultant will be assisting with. Gallagher, Mr. Nick Long, will be stopping by possibly next month, in the month of March, and we'll have a session such as the one we're hosting today so we can provide you some options. The options that we could possibly entertain are having an on-site, near-site, or outsourced clinic. But again, those are details that most likely we'll be visiting during our next meeting. Okay, so this is the part where I think we're going to spend most of our time. And this is just to start reviewing a report I received from Gallagher, where there are basically benchmarking how we look against other public entities, other employers within Region 19, employers with a size of 5,000 plus employees, and self-funded health plans. The first slide you see, we have listed the deductibles in co-insurance. And as you can see, again, this is not something new per se. This is something that we already know. Socorro ISD offers a rich health plan. Employees they're fortunate enough to have a plan that is, low in cost, in out-of-pocket when in comparison to other employers. In addition to that, we have out-of-pocket maximums. And again, this is just to give you an idea of how we look when compared to other employers within, like I mentioned, the public sector, Region 19, and so on. Then, I know I'm going fast over the slides, but bear with me. It'll make sense in a couple of minutes. We have co-pays. The co-pays, pretty much same trend. We have set co-pays that are very accessible, or that we like to think are accessible to our employees. In addition to this, when we look at the data that we get back from Gallagher, we pretty much came down to what we have been talking about during prior meetings, that it has to be a combination of different efforts for us to be able to minimize our health fund deficit. And I don't know if you recall that about a year ago, we talked about the amount of money that we're under when it comes to how much money we were spending and how much money we were, for lack of a better word, charging for those coverages. So in consulting with Gallagher, if you look at the wording in the circle, or in the middle of the circle of the slide, you'll see that pretty much every bullet point or every line item is in line to what we're trying to accomplish. We have different carriers that provide healthcare management to include our employee assistance program. We are looking into the possibility of having additional resources for our employees, which include the employee clinics, cafe, or you might already be aware we have on-site seminars as well throughout the school district. Well-being goals, as you know, we have a wellness initiative that where we schedule different types of activities throughout the school year. We have a multi-year strategic roadmap, which is what we have been looking at since the prior health plan year, where we were fortunate enough to get approval from the board to apply phase 1 of that 3-year plan, or 3-phase plan. In addition to that, we have basically what we're going to be reviewing next, the program design, incentive strategy, assess, measure, and report out. So I mentioned earlier that this will make sense, and I'm hoping with this slide. Here you'll be able to see that when it comes to the cost share, when it comes to what we're offering in the area within Region 19, employees of the school district, we're lucky. We have a very, we receive a significant amount of contribution on behalf of the school district. Socorro ISD per member per month contributes $575 a month. Clint ISD around 310, EPISD 435, Isleta ISD 434, and Canotillo ISD, which is the one that contributes the most within our area, is 623. So again, we're a school district that we can say, fortunately, we are able to contribute or make a significant contribution towards what has to be paid on a monthly basis as a premium. And then a little bit further down, we see what the cost currently is per month in comparison to other school districts. The table down below, where you see Premier 90/10, Base 80/20, high deductible 100%, is where we see the proposal or the recommendation for our next 2018-2019 plan year. And what we're proposing in this slide, again, this is just a draft, that an increase of $40 be applied overall to the Premier plan, and a $20 increase to the base and high deductible plan. So in addition to the increase of the $40 or $20, we're proposing an increase, recommending an increase on annual deductibles and maximum out-of-pocket. Though what we're doing, there is a deductible, a $200 deductible that currently is applied per hospital admission. What we're doing is we're removing that deductible for hospital admission, and we're applying a increment of $200 for the full year. Then you'll see that we have the office visit copays. And within this table, I included telehealth. And I don't know if any of you have any questions in telehealth or how it works or the intent of having telehealth. Urgent care, office visit copay, and emergency room visit. Some of the increases that we're contemplating are to be able to, rather having to make drastic increases to our premiums, is to hope that our membership will shift to a different option to where that trend or that cost sharing is different than what we're experiencing right now. Right now, we have a significant amount of people that require a significant amount of medical care or prescriptions and they are under the Premier plan. As a result, we have, again, a very rich plan that's paying more than what is receiving back into the plan. And that's basically what's causing, at the end of the day, the deficit. Further down on that table, we have the monthly rates, and we're providing you with a breakdown of, again, how much is it that the school district will be contributing on a monthly basis and how much it would be contributed by the employee, again, on a monthly basis as well. Do any of you have any questions on any of the two slides that are making the comparison within the area, Region 19, and or the recommendations that we're making for Phase 2?
Mr. Guerra,
Mr. Yee.
could you please back up to the other slide? So, So the thought is on the Premier plan, it would basically go from 660 employee and family for Security to 700 is what I just saw on the other side. Or what I see on the bottom there, phase two.
Yes, sir.
A $40 difference.
Correct.
Yeah, the 700 scared me, but I realized we're working off of a 660. I thought we were working off something else. I will tell you, I like this slide. I use it all the time because even when you go over here to Canutillo, that provides about $50 more than we do, the minute you look down the list, the employees are also paying a lot more. And so
Right.
certainly what you all are doing to manage our healthcare, I think we're still providing a great healthcare to our employees, and our cost is not this cost. And I
Right.
realize Mr. Reza probably would have some comment on that because we're still having to supplement that by several $1 million in order to balance that. But even that, we're still doing very well in what you all are doing to manage our plan. Thank you.
And the changes that we're recommending, we always keep in mind, mainly, like you said, our employees. Make a change to where we are going forward towards our goal, which is reduce that deficit and have a minimal impact when it comes to the employee. Because at the end of the day, this is going to affect their bottom line. But do we need to make changes? We do. It could possibly be different changes, but at this point in time, if I may, the slide that you see or the information that you see right now illustrates how we could possibly look, or we are anticipating to look, if we don't make any changes, or by making only the changes that are being proposed as phase two, and or in addition to the changes that we're proposing or recommending on phase two, add some additional features that will benefit our employees, in addition to a slight increase in the stop loss deductible, that by doing that will decrease our administrative fees. So I'll start with the first table that starts with 1718 costs. If we were to not make any changes and we were to continue with the plan design as is, we're anticipating that at time of renewal, by the time that we conclude our plan year, most likely there will be an increase of 5.1%, which of course is going against what we're trying to achieve, which is make that number go down rather than going up. If we were to receive approval to apply those changes or those plan design changes as suggested on phase two, that 5.1% will become now 0.5%, which basically is just helping us stay flat. There's not a significant amount of savings, and there's not a significant amount of overspending or increase in the deficit. Yet, in applying those recommendations on phase two, in addition to the one guide and the engaged managed care that we have available through Cigna, we can incorporate additional savings. In addition to that, we also have a rebate minimum guarantee of about $800,000. If the changes are approved as recommended, we have about $3 million in savings. And the engaged care management consists of, rather than following through with someone who became ill or was discharged from the hospital and could possibly receive additional assistance in terms of what other services might be available to them, the engaged care management will do somewhat of a preventive approach, meaning if they see that someone who has been receiving some sort of treatment could benefit from receiving a mammogram, going through a biometric screening and so on, they will take that extra step to have that conversation with that individual, remind them to take their prescription, remind them to follow their care, remind them that if possibly they go to other resources such as outpatient facility and so on and so forth, that could benefit them as well. All those items listed to include the increase in the stop loss pooling to 450,000 will result in we're anticipating will result in a savings of 1.9%, which is, we're hoping, what we're anticipating is that about 2% will be saved rather than seeing an increase on our expenditures. I don't know if you have any questions related to any of the amounts that you see on this slide.
Mr. Carmona, first off, the second column and the last column are exactly the same. I'm assuming that if we were going to implement some of these changes, we would be taking the reductions from the 18-19 cost with benefit change impact, right?
Correct. So yeah, sure.
Just to clarify, what we did was, we took that status quo renewal of the 70 million, moved it to the last column, and then made the deduction. So if you see that $3 million benefit change, that actually foots to the middle column, that 67 million. So if I take the 70, so we kind of just to show, if you do all of these things, this would be your expected savings.
Okay, and then how would we realize if we're already getting the guarantees that we're entitled to according to our contract, how would we get another 820,000? I mean, to me, that sounds like, well, you increase the rebate by increasing the usage, which is counterproductive. You don't get a bitter discount by just spending more and more and more.
Well, actually, we were able to become a little bit more aggressive on the RX rebate. So if we look at the negotiated contracts that we're currently under versus future contracts, that 822,000 would be in addition to the current rebates that you're receiving based on, and of course we look at Socorro's the drug mix, the use, all of that. We can project it based on the new contracts.
So that assumes that we'll be, because those contracts aren't with us, they're with Cigna, correct?
Correct.
So then we can't force Cigna to renegotiate those contracts, right?
They've been renegotiated, and those are guaranteed. That 822,000 is an increased guaranteed minimum. So Socorro will receive, that's our guaranteed minimum.
So whether we do anything or not, we're getting that 822,000 already.
Correct.
Does it also assume, though, that people will make switches from name brand to generics as well?
Well, most of the rebates are going to be on your brand and non-preferred, and what we do is we look at your current utilization and we use that to forecast. Your plans already have a very high generic utilization, so I wouldn't expect a dramatic shift in behavior based on what you're doing today into the next plan year.
Another question, are those rebates, because you mentioned brand and non-preferred. I recently had to purchase a medication, and on my insurance, which is not the district insurance, I certainly experienced that, was $300 for 5 days. And so I was really thinking, is dying so bad? $300. But
And would it hurt a lot?
yeah, that's even more important. Would it hurt a lot? But when I went to the manufacturer's website, I got a rebate coupon from them, and I ended up paying about $75. Huge difference. So my question is, does that rebate that I took from the manufacturer then cancel out these rebates and I was quite upset. As a matter of fact, I switched the pharmacy that I go to because I thought, well, why didn't the pharmacy tell me that? You know, when I showed up. So, I mean, if more and more you're seeing this on drugs, and it is the latest drugs because they advertise so that people ask for them for their doctors. So, are we going to cancel out this ability to get these rebates, you know, if we do better at educating our employees and they get the rebates themselves? So do we get these rebates at the expense of our employees, I guess is the specific question.
Mr. Nakara, let me get this straight. We want you to do extreme couponing now?
That's about right. No, but people do it on their, you know.
Pretty good, eh, man?
And the only reason I found it,
That was really
yeah, and the only reason I found it is because I Googled it. I'm like, what the hell are they giving me? You know, and the first thing that pops up is a rebate. I'm like, oh, I don't care what they're giving me. It's only $75. Change in behavior.
So, if I'm gonna live.
I'm still here.
So, there's a multiple ways that I could answer that question.
Truthfully would be best.
Okay, I'm not gonna lie. No, what I would say is that our Cigna's approach to management of the formulary is we look at having while rebates are good for the client, they are not necessarily beneficial for the customer. So we purposefully look at our formulary and are not putting on high-priced, high-rebate drugs. We are looking to manage our formulary in a way that we're bringing cost-effective drugs to your employees. The drug industry is, as you know, the pharmaceutical industry is out of control. One way that they can combat us managing the formulary tighter is to say, hey, look at, I have this coupon over here, come buy the drug for me. So it is a very delicate balance in managing a formulary. But absolutely, to the extent that you go to the Lyrica website, not that you would not, but the extent that somebody would go to the Lyrica website and pull down a coupon that would make it less expensive out of their pocket than if they use their benefit, that's what the pharmaceutical industry is trying to get you to do.
Okay. Mr. Carmona, I noticed One Guide is capitalized. What is One Guide?
Sure. So One Guide is our enhanced customer service model. So our customer service, 24/7, 365. Some of our clients have come to us and said, we want you to take the opportunity to engage with our employees differently. So when somebody is calling Cigna, that's when they want to talk about healthcare. So we have this enhanced customer service model that allows us with personal guides to take the opportunity to relate in a different way with somebody when they're ready. The traditional customer service model is to call people. Well, they may not be wanting to talk to healthcare at that time. So this customer service model really takes advantage of that opportunity to drive different engagement. If you call, I'll give you a quick example. If you call and say, I need help with a physical therapy, we'll say, okay, here's some providers. What else can I do to help you? Or have you been helped? In the new model, in this enhanced model, the One Guide, we'll take the time, we'll increase that engagement to, do you understand your benefit? Do you know that after you have 5 visits, you're going to have to go through medical necessity review? Do you understand what that means? And so it's just a little bit, it's more of a concierge type of customer service that we feel like for Socorro would be the next step in driving different outcomes relative to employee health.
Mr. Carmona, does our, is it Miss Yates, right? Or
Bebo.
Bebo?
Yes.
Okay.
Reeves.
Oh, Sally Reeves. Who's that?
That's her.
Oh, okay. So, Ms. Bebo, are you with Cigna?
Yes.
Okay, good. Tell me, how is that, oh, Mr. Carmona, does our base plan require a primary care provider?
Neither
It
one
does
of them.
not. Okay.
Though we're hoping that by applying certain changes, and again, it may not be significant, that will assist employees in making, know that they have different options. It doesn't have to be a doctor's visit per se if you feel that you have a sore throat or, what you come down with every single year. If you can do it, you feel comfortable enough to do it over your phone and video chat with a healthcare provider who can possibly do the consultation, and in addition to that, call in the prescription for you, then that will save in turn money to the plan as well.
So right now, our current benefit option doesn't include a 24-hour nurse?
There's a
hotline?
24/7 nurse line. but
Okay,
the
and is that
nurse
staffed by a nurse or a nurse practitioner?
It's nurse practitioner, right? Though they will not call in a prescription for you if you need one.
They're not practitioners. Right.
Yeah, there's two, so you have two different benefits. You have the 24-hour information line, which is, I've just burnt my hand, what should I do type of thing. But then you have telemedicine, which is, I've just woken up and I have a, sore throat. I need a prescription for Tamiflu or whatever. You can call the telemedicine, speak with the physician, and they can write a prescription for you. So it's two different benefits.
So I'm just curious, because most of that, to me, that sounds two different things that I heard. You mentioned one program, which is ready to engage them when they're ready to engage. Most people go to their physician for that, but I know that I think it's been a while since I've been on the insurer side. You all still have the HEDIS reporting requirements, don't you? Do you know what the? And so a lot of those drive your action already, trying to make sure that patients are getting, their annual exams, et cetera. So, and I've seen the mailers as well. So, or physicians' offices. So I just don't understand, the difference. Is this a program? I don't even know how to answer the question. How to ask the
Were you
question.
asking it?
Yeah, there you go. What I'm saying is that, if I don't feel well in the morning and I think I need a medication, depending on my relationship with my physician, right, I can usually call my physician's office and say, hey, I'm not feeling well, these are the things, whatever. And if it is someone that you see frequently, they themselves might call it in, or they're going to ask you, to come in as well. As far as additional information or additional reminders, the physician's office already does that as well. And, if people are ready to engage for some type of treatment, it's probably because they're already engaged in going to their physician's office. So, although in theory the program sounds great, practically speaking, I don't see where we're going to save $900,000 on, minimum claims. But I guess you're basing it on something, right?
Yeah, yes, correct. There were a couple of questions in there, so I'll try and answer them as I heard them. The first I would say is absolutely, we encourage a primary care physician relationship. The fact is, when we look at the Socorro data, there are only about 50% of your employees have had some type of preventive exam in the last 12 months. So that's one way avenue.
Now, it depends on the age of the population as well, because...
age appropriate.
Okay.
Age appropriate. So that's absolutely one avenue. When we're talking about the one guide customer service, it's not so much about diagnose me with a medical, like I have a sore throat. It's more about how do I navigate the healthcare system, right? And what resources do I have available to me if I need to find something or go somewhere for a treatment or service. This is a customer service model, not a diagnostic model. And then lastly, what I would say is, when we're looking at that $990,000 claims decrement, it's actually two programs that we would recommend. The One Guide and then the enhanced care management model that Mr. Carmona spoke of. And those are based on our book of business. This would be for the implementation of those two programs, we would expect to see that claim decrement.
Yeah. Okay. I mean, I think Cigna's pretty effective at, managing or encouraging people to navigate, because it's pretty simple. Either you have or meet the medical necessity for the treatment, or you don't, and what it's going to cost you when you don't, or when you go to a provider, et cetera, is causes desperation itself when you need the treatment for you to start looking for something that either does fall within the plan, or that you get the correct diagnosis code, et cetera. Okay. Thank you, ma'am. Mr. Carmona, on the stop loss, I heard you say that maybe to prevent our stop loss premium from going up, but yet as I look across, it's the same in all of them. And then, okay.
Sorry, and are you referring to the first table, or?
They're all
Well,
the same.
they're the same all the way. Well, not the first column, but when you go to status quo, 1819 costs with all changes, the premiums will increase, and they increase in each column. So,
Right, so what we do is we look at the number, an average number of high dollar claims. And that's the reason why, since it's the same number, there's no change being implemented to the first two tables. On table 3, if we were to do an increase of 50,000 for the deductible rather than 400,000, which is what you see on the first two tables, then we would see a decrease in our administrative fees of 146,000.
what does that have to do with the stop loss premiums, though?
We pay a fee per case per se, and we pay a deductible per case as well. So rather than paying 250,000, rather than paying a higher administrative fee, we can decrease that administrative fee by increasing the deductible by 50,000 per case.
Mr. Carmona, and what's the nature of those stop loss claims? Because from my experience, those are, catastrophic events.
Correct.
Somebody getting into a car accident, somebody, having a heart attack with severe complications or something like, yeah, there you go. Those are things we're not going to be able to control.
Correct.
We can't prevent them either. They're going to happen.
Right.
So, how do these changes impact that?
So if we were not to have the stop loss, let's say that with two of our newborns that we have had within the last 12 months, right, we could basically just have another deficit of so many million. So to avoid those type of situations to where we're spending that money, we have something in place like the stop loss insurance, to where we're saying once my claim, regardless of how many millions, once it reaches 400,000, that's where we stop. And then,
And that I understand, but we can't control how many of our newborns are going to end up in the ICU and stay there for 6 weeks, 6 months. That is well beyond our control. So I don't understand how our premium is going to decrease by taking some action. What is that action? Because there's no way that we can prevent those catastrophic events from happening. That's completely beyond our control. So
Right.
how are we seeing a reduction?
So,
I mean, to me, it sounds like roll the dice. This year, we don't get that many, but next year we do, and the year after that, it may double, because it's just, you don't know. So
right. So,
how are we?
So two things. The first is the actual purchase of the stop-loss insurance, and that's really like purchasing car insurance, right? You pay-
Understand that, we're doing
you
that
pay a
right.
premium.
Yeah, we're doing that right now. I'm not concerned with the premium.
Mhm.
I just don't see how we can prevent the premium going up, because the very nature of those claims are beyond anybody's control.
Absolutely, absolutely. So what we're saying is, based on your current premium at the $400,000 stop-loss level, you'll pay X amount of dollars. If you increase that to the $450,000 level, your administrative fee will go down, because essentially Socorro is bearing more of the risk, so you're paying a lower premium. Historically, and what we would expect for a client of your size would be 5 stop-loss claimants. You did have $2 million claimants this year. So, I mean, but of a claim of your size. So that's just the premium aspect, right? What risk are you going to pay for, higher or lower?
I get it now.
Relative to,
So by assuming a greater risk, by increasing the proportion that we are responsible for by $50,000 from $400,000 to $450,000, then our administrative fee goes down, because
Correct.
the possibility is, that we're going to be, you mentioned $2
right.
million
we don't know.
claims, so we're going to
Nobody
pay an
knows.
extra for
Yeah.
those 2 claims, $100,000. Okay. But the flip side to that is, even if we assume that 450, and this year, and everybody knows, the more claims you submit to insurance, the higher premium's going to go. So the savings, may not be the same, because, again, the claims that come through are not within our control.
Right.
But, okay.
That 150,000 is hard dollar savings, right? So you will see that savings by increasing your premium.
Only to the extent that we don't have to pay 3 claims
Right.
at greater
Yeah,
than $450,000.
Exactly, it's the risk. What I would say is, there's 2 things. Where somebody goes for care makes a difference in terms of the cost.
Not for catastrophic events. You go where you end up,
Well, if it's an emergency, absolutely.
which is what we're talking about with stop-loss subjectivity.
Or if you go in for a knee surgery and you get sepsis and you have to stay in the hospital for, 10 days, that claim is now, turned into a $500,000 claim. So where you go makes a difference, and then the
But in
type
that
of-
specific situation, that's a nosocomial infection, right? And I assume that Cigna has measures in place to prevent that as well, correct?
Absolutely, right. So to answer your second part of the question, the care, there are additional ways to help the cost of an episode. And so one of the program that we're talking about, that enhanced care management, the example that we used in the HR workshop was, when you go in for a knee replacement, when you're trying to be discharged, that's not the time to find out you can't go home because you're upstairs and your bathroom's on the 2nd floor. So what we are proposing is a model that would use data analytics to be able to identify people before they're admitted into the hospital based on high-risk codes and other data points, so that we can assist them, get them out of the hospital into the right care. There's a social worker component to that. So to answer your question about how do we control those larger catastrophic events, you can't, right? If I'm having a heart attack, I'm having a heart attack, but how can we help mitigate the higher costs that come once you've had that catastrophic event?
Okay, so I'm just trying to understand, because, I don't want to take money from one pocket and just, I don't want to stop having to pay from one pocket only to pull it out and pay from the other, because overall the impact is the same, and I mean, I'll have to give this more thought and ask more questions because, I mean, you mentioned case management now and social workers. They work at hospitals and their responsibility is to make sure that things like that don't happen because then you're going to have a readmission for whatever reason and, then hospitals don't get paid. So, some of the things I'm struggling to understand the difference in the program for the increased additional fee and where the reduction is going to come from because a lot of the things that you're mentioning already happen, and they happen in the hospital because that's where the incentive is, so I don't understand how much more impact Cigna is going to have for the additional cost.
We actually have 2 exhibits that answer those specific questions that
Here.
we can share with you, that we shared with the HR board committee last week.
They're not, I'm sorry.
They're not
They're not
included,
part of your
but we
handout,
can
but
share
we
with
have them available.
No more questions. Mr.
Anybody else?
No, I think Mr. Nahara covered it. I think we're.
Mr. Gonzalez?
Yeah, allow me, if you may, to move a little bit. It, to me, it's a lot more complicated to get into the micro part of the system, as Mr. Nahara was getting. And to me, it's a lot easier to move a little bit into the macro part of the system. Now, all these numbers that you have, did you consider, for instance, that a lot of companies now can do business across states and that the price of doing business is going down and the competition is increasing? And also that on the drugs provided, new policies are being put in place to make it more affordable, like, for instance, that experimental drugs that now can be, or you are allowed to use. So if you use the numbers that were in place in 2017 before these reforms came in, it does not allow to create an expansion to the right of the curve to see that the future, we can have if you receive more savings and the way you provide the taking care of the claims and stuff like that, how are we going to see those benefits on our side?
Well, I think that what we're looking, where we see opportunity when we look at the Socorro ISD data is to engage earlier so that we can identify and avoid some of those larger costs. So what we typically do is we'll look at your experience and we'll say, what is a best-in-class outcome and how do we get there? But those are going to be dollars not spent as opposed to dollars that we give you. Does that?
I guess what I'm looking
not
at
sure
is
that
that
answers your question.
you base this model
Mhm.
on what was happening in the year 2017 and trying to correlate into 2008 and 18, cause and effect type, which a lot of the times you cannot do because you may be considering 2 different things that even though it appears that be correlated, they're not. For instance, I know that most of the employees have gotten a pay raise that would, if we were to increase our co-pays to $40, it would be a little bit easier, although I don't know to what extent for them to be able to meet that burden. And I don't know, on the same hand, how much benefits or did we receive from that tax cut as a district. So if I want to move the cost consumption curve to 2018, if the prices drop, that would allow me to move a little bit further to the right and allow me to produce and have better treatment for everybody, better medical care. So I guess the question I have is, if we do realize in our near future cost drop across on doctors, on hospitals, on how are we going to benefit as a district from that?
Isn't it that we're a self-funded district, so we
Right,
would
you'll
realize
spend
direct benefit?
less. Yes,
Well, and I
exactly.
think what we're
So-
basing on stuff now is known numbers. There are a lot of things that could happen, may happen, and may or may not happen. At that time, we would make an adjustment. I mean, we just can't guess on it now.
Yeah, exactly. So when we're doing our expense modeling, we look at the current spend, where it's being spent. We trend that for medical trend. Now, if we're using 8% medical trend, if the trend comes in, at 6%, that 2%, because you're self-funded, that's money you haven't spent. As opposed if you were fully insured, you would not see any benefit from that. So that is when we're looking at the monthly claims, you're spending less than you spent before because you have that price reduction. Because you're a self-insured plan, you pay the claims, we administer them, you pay them out of your bank account. So to the extent a physician goes from an average of 134 to 130, that $4 is are dollars that you haven't spent. So that's how you see the savings, because you're not spending the money.
Thank you.
Any other questions? Thank you.
Okay, next we have some information from our finance department. Mr. Reza, I don't know if you're going to be.
That's not the slide I sent you, though, right? There it is. So, I mean, you want to go ahead and just go over it real quick? Or?
Sure. So here we have a historical data when it comes to our health fund history. And the first table, titled Fiscal Year 2017, pretty much shows the experience for that current plan year. For fiscal year 2018 up to January, you'll see that the ending total net assets is 2.3 million. Right next to it, followed by the fiscal year 2017 January healthcare fund, which is 2.4 million as well. This is just to provide you a comparison at the very end with a table titled Difference from Prior Year Healthcare Fund of roughly close to $1 million. And what we're projecting in terms of district year-end contribution, the total is listed on the table below. And the table, if I recall correctly, it includes the changes as proposed on phase 2, which includes the increase of the deductible and the increase on the employee premiums.
Yes, sir. So I just want to add, with respect to the district, the year-end revenues, we're projecting for 2018, this fiscal year, to end up the year, district contribution, $38.3 million. That's not only the general fund, but all federal programs, which includes Title I, anybody funded out of Title I. It also includes our child nutrition program. That's what we think. We're estimating that we're going to end up with a contribution. Our employees' contribution, we're estimating to be $9.3 million. There's some interest earning savings for the plan. And then we're projecting that at the end of this year, we'll have to do a budget amendment out of fund balance and probably make a contribution of about almost $6.7 million to be able to end up in the black or maybe even. And that's the projection. So what you'll see is last year we did have a $5.6 million net asset, like a fund balance, a positive fund balance. It's no longer there. We did a year-end $4.4 million end-of-year contribution. I was hoping to end up a little bit in the black. However, our Lag report came in higher, about $300,000 higher than in prior years, and so we ended up with a $72,000 negative balance. So currently, we have a negative balance of $2.3 million, when last year we had a positive balance of 2.4. So just for your information, that given we don't make any changes, we'll have to make this particular contribution at the end of the year, and we'll probably have to make another one next year. Also keep in mind that you'll see that increase in the district's contribution. We did increase our contribution, as Mr. Carmona said, by $25 per employee. So we went from $550 per month to $575 per month. And we also added to the budget because of additional personnel. So, thank you, Sir.
I don't know if there are any questions on the numbers that you see before you.
Any questions?
One.
Commissioner Nahara?
Mr. Carmona, the previous slide and this slide, what's the difference between them?
I just have the revenue at the bottom.
Okay.
That's it. And
Eddie.
I put it as a placeholder, and then I did send it. I mean, it wasn't finished.
Okay,
That's,
I get it. Oh, no worries, no worries. Okay.
Mr. Carmona flashing the
At this point, I don't know if you have any questions in regard to any of the items that we have covered so far.
Yeah, Mr. Carmona, let me pull out my list.
I was gonna say,
Just kidding.
Ms. Nájera, the way she's looking at me, she's like, no.
Mr. Guerra, I do have a few questions because I don't think enough were asked. What time are we going into executive session?
As soon as there's no more questions. Any more questions? No. Thank you, Mr. Carmona.
Thank you.
I thought we were done. Item number 4, executive session. The meeting is to be closed to consider administration recommendations for assistant principal positions at James P. Butler Elementary School, Lujan Chavez Elementary School, Mission Ridge Elementary School, and Sergeant Manuel R. Fuentes Middle School under Texas Government Code Section 551.074. The time is 6:44. The board is back from the administrative executive session. The time is 7:07. We'll move on to new business, 5A, assistant principals for James P. Butler Elementary School. Dr. Espinosa.
Yes, President Guerra and members of the board, at this time, administration is pulling this item from the agenda.
Next item, 1B, Lujan Chavez Elementary School.
Yes, President Guerra, members of the board, at this time, administration recommends Ms. Naomi Martinez to assume all the roles and the responsibilities as assistant principal at Lujan Chavez.
Motion to approve.
Second?
Yours.
Have a motion.
Hector.
Have a motion by Mr. Gonzalez, second by Ms. Rodriguez. All those in favor?
Aye.
Opposed? Motion passes. Next item, 5C, Mission Ridge Elementary School.
Yes, President Guerra, members of the board, at this time, administration recommends Ms. Jennifer Ellis Martinez to assume all the roles and the responsibilities as the new assistant principal at Mission Ridge Elementary.
motion to approve?
Second.
Second. Have a motion by Ms. Nájera, second by Mr. Gandara. Any further discussion? All those in favor?
Aye.
Opposed? Motion passes. Item 5D, Manuel Fuentes Middle School.
Yes, President Guerra, members of the board, at this time, administration is pulling this item from the agenda.
Thank you, Dr. Espinosa. Since there's no further business with the board, meeting's adjourned at 7:09.
He's got it.
I was just gonna ask you.